Um, I became, well, about myself, when I decided to become a nurse, I was really, really young, and I've actually been doing nursing for 13 years now. Prior to that, I started as a nursery nurse, and I decided that, I wanted to look after grown-ups. I then became a healthcare assistant at Maidstone Hospital, and I did a lot more, than what a healthcare assistant would do up there, and that's when I discovered that I wanted to become a registered nurse. So I then applied to go to university. I did my training and worked on many different wards during that time. And then as I qualified, I worked on the oncology ward up at Maidstone Hospital, which I absolutely loved. However, there wasn't the time or the resources to give palliative care up there. And one of my friends worked down here at the hospice, and I decided that, I wanted to give it a go. It was actually a patient who I'd looked after on the ward who had become really, really poorly, and I'd looked after her during her whole journey. Even when I was a healthcare assistant, she had metastatic breast cancer, and I'd seen her through her chemotherapy, through her radiotherapy, through her surgery, and it had got to the ward, when I was qualified, and she was for end of life care, and we were transferring her down here. And the day that she was coming down here, it nearly broke my heart, because I think I'd possibly got a little bit too involved, which, sometimes is absolutely impossible not to. And I thought, what, I really wanted to follow through the care until the end of life. And that's when I thought I was going to start a job down here at the hospice. And I've been here 4 years this year, and I absolutely love it. And I can't imagine myself working anywhere else. So that's me, quite bubbly, probably, I'm the youngest staff nurse here. Have done nursing more than some of the other girls, probably some of the healthcare assistants. I've been doing the nursing a little bit long from there, but I like it, and I think some of the staff like it, because I have started at the bottom. I appreciate what it's like to be in all the different roles, and I got my senior nurse position about a year ago now, so I've got a little bit more authority and responsibility here, which is what I really like. Again, because the patient, a lot of patients did die on, on Charles Dickens, the oncology ward that I worked on, and because you'd look after 8 patients really, and you'd find that you were, not all of them were for end of life care, but you'd be chasing your tail all day, and I wanted to spend time with the patients who were dying and the families, and I didn't quite have the time there, and that's when I knew that the ratio of staff to patients was much different down here, and I knew that this is, set up in a palliative care environment, and this is what this place is all about, and that's why I thought, what, I'd never worked down here when I went for the job, but you hear so much about it down here, and as I said, my friend worked down here and always had excellent things to say about it, and that's why I thought, what, I'm going to give it a go. Today has been slightly more rushed. It varies so much here. Sometimes we can have hardly any patients, and then other days, every day is a different day. We do a referral meet. Well, I'll talk about when say for example today, I'm in charge today. I'm not a team leader, but because I am a senior member of staff, whoever the senior member of staff is, that's the person who takes charge of the shift. So I come on duty at 7:30 in the morning, and I take handover from the night staff. The night staff hand over till about 8 o'clock in the morning, just tell us about what kind of night the patients had, and about any family issues that might have arisen, any symptoms that the patients have got that possibly aren't being controlled well. Then I would go and I would introduce myself to all my patients in the morning. I'd look to see what 8 o'clock medications they've got. They might have a syringe driver, so I need to try and identify if the syringe driver needs changing, if the patient's comfortable or not, if I need to then speak to the doctor to decide if the patient's drugs need to be changed in the syringe driver to make them more comfortable. Personal care is a big thing down here, absolutely love doing that. Sometimes typical people say, too posh to wash when you're a nurse. Down here it's not like that at all. The thing that I love about it is we all roll our sleeves up down here, no matter what status you are, no matter what type of nurse you are, and I think it's paramount personal care down here. You get to talk to the patient, you get to see what any problems are, what pressure area damage they've got. So do that, and then again, looking at medication. If patients have got problems with symptoms, you're trying to sort their symptoms out throughout the day. You've got the lunchtime, so you sort out that, you help them with their meals. Some people need feeding, so we do that. liaise with the doctors. On Tuesdays we've got the multidisciplinary meeting. When you're in charge, you go to a referral meeting. First of all, you have the handover, the doctor's handover, which is about 20 to 9 in the morning. And you just discuss about with the doctors what kind of night the patient's had. And then at 20 past 9 in the morning, we then go upstairs and speak with the community team on a daily basis. And we identify what patients are in the community which possibly need to go on the waiting list to come in, or what needs to go on the potential waiting list. We then decide what kind of staff we've got on duty, if we've got enough, what beds are available, and then we decide if any patients need to come in. And then that's just the way the day goes, really. It's so different. And and you're dealing with families all the time. Some families obviously take a lot more support than others, but that's what makes the day interesting, and I do find that generally, because we have got good staff ratio to patients, we do get to give the families all the support that they need. And for me, that really is paramount, that because I think with end of life care you only get it right once, and that's why you need to make sure that you do it properly, and I think we do down here. I suppose really it is funny, with certain patients. Some people, you take to more than others. There's some, I don't know really. Some of the younger ones I find it easier to relate to, but then some of the older ones you do. It's always going to be a member of your family. It could either be your husband, your wife, your brother, your sister, your grandma, your granddad, your uncle or your auntie. And I think, I've had lots of funny stories before. I had a patient, a brain tumour once, who, was in bed all the time, and we just had such a giggle all the time. And because his memory wasn't fantastic, every single day, we'd go in and he wouldn't remember 5 minutes ago, but he was such a happy patient as well. And, we would just giggle, we'd dance, and we'd sing to the music that he had on the television. And it was just lovely. There's certain memories with particular patients that I'll always have. I would say that the idea of death is frightening. When I started down here, I will admit, hands up, I got far too attached to the patients, and my husband would probably say that I was a blubbering wreck, really. But I would say probably for the first month to 2 months when I started here, I got way too emotionally involved, and I did find that I was starting to take my work home with me. And in all honesty, I did question whether this was for me down here, because it is so upsetting. It really is, especially when I've looked after 18-year-old people, and some people are still children. Even when it's somebody your age as well, it really makes you look at your own life. And I tell you what, it makes me appreciate things so much more. Don't ever leave on an argument. Don't ever. If you want to do something, make sure you do it, because you just don't ever know what's around the corner. And I think there's one part of me that I don't think I'll ever understand, because I am afraid of dying myself, and I think that's just because I know how precious it is and how it can just suddenly happen. We get patients, unfortunately, that come down here who have just been diagnosed, who have been poorly for such a long time, yet they didn't realise, unfortunately, some people say, well, I've had this pain for ages, I just didn't go to the doctor about it. And it makes you scared. I do get scared sometimes. People make a joke of it, because nurses, if they've got a headache, they think there's something wrong with them, because I think there is a fine line between getting a bit too involved, thinking that, everyone's going to die. But then you need to remember that people do get better. And I think it's really important that you need to keep a good social network when you work down here. You need to remember that not everybody is going to die, and people do get better. And that's why you need to make sure you've got a really good life outside of here, to make sure that you appreciate it. But yeah, I am scared of dying, but I've just realised that you just need to do everything that you want to do in life, but obviously not abuse it. Some patients want to talk about death, some patients don't want to talk about death. Some people really aren't very accepting of death, and I find generally those patients are a lot harder to look after, simply because they have a lot of psychological anguish. I find that people who, come to face with, with their fears and with death, generally have a little bit more of a more comfortable death, and that's because, you know, they're getting their head around what's happening, they're talking to their family members and they're discussing what they want to happen. There was one day, and it was a young woman, I think she was about 49 years old, and all she wanted to do was go to the seaside, and you know, she was so poorly, and a lot of us questioned whether she could actually go to the seaside. But what we done was we got her up really early in the morning, gave her a really nice wash, got her really wrapped up, got her in the hoist, into the wheelchair, and had organised a taxi for her, and she went to the seaside, and she died the next day, but she had the bestest day of her life. She went and sat and she watched her family eat fish and chips because she wasn't able to eat fish and chips. And it's just that, it gives me goosebumps. Yes. Because it's just the nicest feeling in the world, knowing that you've helped somebody achieve what they want to achieve. There was a gentleman as well, I remember, absolutely lovely brain tumour patient. All he wanted to do was to go in a Porsche down to Brighton seafront. Well, you know what, it was impossible to get him in a Porsche because, you know, he needed to have a wheelchair, he had left-sided weakness. But we did it. We got him in, okay, it was in a taxi, a disability taxi, but he had a brilliant time. He was down with his friends. There was 2 of his friends that he went with, and they were smoking cigars, whizzing up and down, you know, the seafront, and they took photographs. And you know what, he was knackered, but you know, he talked about it so much, and I think he died a couple of weeks after. But knowing that we'd helped him to achieve that, it's just such a wonderful feeling. Sometimes people have been in bed for absolute weeks, you know, people that perhaps have been at home, you know, it's been easy, they've wanted to stay at home, but they've, you know, become bedbound and they want to come in, and you do get institutionalised sometimes, you know, sometimes you're in your bed, anxiety builds up, confidence drops down, and it's really frightening, and I think you get shut off from that outside world. And sometimes, you know, we had a lady in here earlier, she is frightened. She will be going home to a nursing home soon, simply because she doesn't require palliative care needs here so much. But she's frightened to get out of bed, but we got her washed and we got her in the wheelchair, and you know, she got to sit in the garden room with her family, and it's just getting her out, that different scenery, just, you know, forgetting for one moment that you're poorly and that you're stuck beyond those 4 walls. And the gardens here are so lovely, and in the spring and the summer, walking around looking at all the plants and the gardens is absolutely lovely. And sometimes, you know, sometimes that's all what patients have got, but I think it really makes a difference. A lot of people that don't know about the hospice say, oh, but you must be on antidepressants working down there, I bet it's really miserable, you know, how on earth do you not find that you're crying all the time? And I suppose when I came down here, I had that expectation. But you know what, it is the opposite, because if you were dying and you had somebody being all miserable with you every single day, that's not how you want to live, you know, finish your days. I find that we're almost the complete opposite here. We are full of laughs, we are full of smiles, and people absolutely love that, because you know what, if you've only got a week, if you've only got a few days or even a couple of months, you want to enjoy what you've got, and quality is so much better than quantity half the time. And if we can, I did a reflections interview a couple of years ago, and I said, if I can go in and I can just make one person smile and just make them feel one moment that they're out of this situation, and that, you know, that things are going to be all right, that they're not to be frightened, then I know that I'm doing the job that I want to do. And I am bubbly. A lot of people say, oh, Laura, you're like a child, because that's me, that's who I am. And I find that, you know, you do have to be careful. Not everybody wants to be happy and bubbly. A lot of people do find that, you know, you do get some patients that are depressed, you know, they just want out, they've had enough, you know. None of us really truly know what the backgrounds are of some patients. People have got their own complex situations, some people have a lot of family dynamic problems, and I think that if we can turn that around here and we can just make them happy and just, you know, give them the best time of what they've got left, then that's so important.